Hello, everyone, and welcome. My name is Alannah McEvoy, and I'm currently a postdoctoral fellow within the McCall MacBain program and within the Salmon Lab here at MacMaster. Today, I'm going to be talking to you about my research on the role of genetics in opioid use disorder treatment outcomes. For many of us, we extremely dislike the idea of being in pain, and we will do just about anything to find relief. Often, this means finding an Advil, a Tylenol, or some other form of over-the-counter pain reliever. However, if the pain is severe enough, or perhaps we had surgery or broke a bone, we might be prescribed another form of medication from a doctor, opioids. Prior to the mid-2000s, many of us wouldn't have had a second thought about being prescribed opioids. Because a doctor was prescribing them, they were considered safe and would take the pain away. Individuals who used opioids recreationally were considered junkies or abusers with serious mental health issues. Drugs were not the problem, drug abusers were. Then, around 2009 to 2015, we started to see a shift in the way that large media outlets spoke about drugs and opioids specifically. We started to see an emergence of terms such as drug users or less stigmatizing language including individuals who use opioids. And the conversation turned from individuals who were seeking opioids leading to crime and theft to being a public health issue and needing for harm reduction strategies as well as treatment programs. Opioid use disorder is a chronic and remitting condition, and 16 million individuals worldwide are estimated to have had or currently have an opioid use disorder. And concerningly, an average of 22 opioid-related deaths have occurred in Canada between January and June of 2023. Individuals that use opioids are at a high risk of developing opioid use disorder, and concerningly, they're also at a high risk of an opioid overdose. The CDC recognizes 3 waves of opioid overdoses. So the first wave started in about the 1990s, where we saw an increase in prescription opioids, followed by an increase in prescription opioid-related deaths. The second wave began in 2010, where we saw an increase in heroin-related overdose, followed by the third wave in 2013, where there was an increase in fentanyl-related overdoses. And to date, we are still seeing an increase in fentanyl-related and carfentanil-related overdoses. So what treatment options exist for individuals with an opioid use disorder? Often, individuals are prescribed medication, a long-lasting opioid, to help with decreasing opioid cravings and withdrawal. Methadone is one of these opioids that might be prescribed, and methadone has been shown to find a decrease in opioid-related cravings and withdrawal. However, there are a lot of individual differences in the effective dose of methadone. So for individuals on too low of a dose, they might still experience opioid cravings and withdrawal symptoms, and individuals who are on too high of a dose can experience drowsiness, confusion, and mental impairment. Additionally, individuals who live with an opioid use disorder have a higher rate of substance use than the general population. And in Canada, we use a harm reduction strategy. So what this means is individuals who are on methadone for treatment might still be using other drugs, including opioids, benzodiazepines, cocaine, cannabis, alcohol, and cigarettes. But imagine, what if we could predict how an individual responds to methadone treatment before they start their dose? So my research has focused on the genetics of opioid use, and we have specifically looked at to see if we can predict an individual's methadone dose based on their genetics. And this would help lower the risk of relapse and opioid overdose for those seeking treatment. What we do know is that our DNA makes us who we are. From the moment of conception, it contains all of the proteins that we will use. A lot of our traits, including height and eye color, are determined mainly by our DNA. However, our DNA is not solely what makes us us. Our environment plays a large role in the areas of our DNA that is expressed. And additionally, genetic research has moved away from this viewpoint of where a single gene causes a trait or disease to a more complicated model, where diseases are viewed as complex, and we might have multiple genes that contribute to a single trait or disease, and they work together to express that. How individuals respond to methadone dose is considered a complex trait, as we see on the figure in the bottom right. So, if we want to understand how an individual might respond to a methadone dose, we can use a polygenic risk score. So polygenic risk scores can provide a measure of which individuals' risks exist based on their genetics for a certain disease or trait. So in this case, our trait would be methadone dose, and we would be looking to see what various genes might be contributing to this. And while more research is needed to understand the complicated relationship between one's genetics and the response to methadone treatment, it's vital to continue to investigate these genetic differences based on the known individual level variability that we have on methadone dose, as well as the possibility for personalized care, such as the image on the left here, where we might be able to understand if an individual would respond to a normal dose of methadone treatment, if they require a lower or a higher, or perhaps they need a completely alternative medication to help with this, such as buprenorphine, which is often prescribed as well. So some future directions from my research. First of all, we need replication. Currently, the variance explained from the genetics is not that high, so we need to make sure that we're seeing this consistently in other populations with a lot of variance explained. We also want to make sure that we're looking at multi-ethnic populations. We know that individuals of the same ethnicity have more genetically in common than other ethnicities, so who's to say that their response to treatment based on their genes would be the same? And lastly, we need larger sample sizes. Genetic research often involves a much larger sample sizes than your average because of the pure amount of variance that we look at. So thank you all for listening. I did just want to make some acknowledgements. So Dr. Zena Salmon, my supervisor, without whom this work would not have been possible. Jackie Hudson, our amazing lab coordinator. All past and current members of the Salmon Lab. McMaster University, of course. CIHR for funding the research. And the Canadian Addiction Treatment Centers, where we were able to recruit participants from.